Hello and welcome to the topic Approach to Hyper and Hyponatremia in the module Endocrinology. At the end of this topic, you should be able to define hyper and hyponatremia, explain the life-threatening causes of hyper and hyponatremia, outline the causes of hyper and hyponatremia, outline the differential diagnosis of hyper and hyponatremia, and finally describe the management approach for hyper and hyponatremia. Let's get started. The term hyper means high and hypo refers to low, and here natremia or natrium refers to sodium. So hypernatremia is defined as serum sodium level over 145 millimoles per liter. On the other hand, hyponatremia is defined as serum sodium level less than 135 millimoles per liter. The life-threatening causes for hyponatremia is hypovolemia. On examination, look for any low blood pressure, raised heart rate, signs of dehydration, and reduced urine output. To investigate the causes of hypovolemia, you can order capillary blood glucose for hyperglycemic-induced osmotic diuresis or renal function tests for nephrogenic diabetes insipidus. For hyponatremia, syndrome of inappropriate secretion of antidiuretic hormone, SIADH, is a life-threatening cause. On examination, look for any signs of hypothyroidism and any signs that could be suggestive of brain injury or malignancy, as these causes mentioned could lead to SIADH. To investigate for the cause of SIADH, order a white cell count, which comes under full blood count. Look for infection. And a chest radiograph if you suspect a lung infection. Free thyroid hormone levels for hypothyroidism. Brain CT and CSF fluid analysis for primary brain injury, for malignancy, and you can order a CT thoracic abdomen and pelvis as well. There are various causes of SIADH. Primary brain injury such as meningitis or subarachnoid hemorrhage can be reasons for SIADH to develop. Besides that, drugs such as carbamazepine, SSRIs, amitriptyline and morphine could precipitate the development of SIADH. Lung malignancy such as small cell carcinoma or also stimulate release of ADH causing SIADH. Infections such as pneumonia and cerebral abscess are predisposing factors of SIADH, while hypothyroidism could also trigger SIADH. Inappropriate release of ADH hormones then bind to the receptors of the kidney, allowing increased water reabsorption, and this eventually leads to decreased serum osmolality and increased urine osmolality. There are several causes for hyper and hyponatremia. We shall start with hypernatremia first. The primary causes include neurogenic DI, which is diabetes insipidus, and nephrogenic diabetes insipidus. In neurogenic DI, it can be further divided into congenital and acquired causes. Congenital causes of neurogenic DI are structural malformations of hypothalamus or pituitary and AVP gene mutations. Acquired causes of neurogenic DI are primary brain tumors or metastasis to the brain. Others include meningitis, encephalitis, trauma, surgery, and idiopathic. On examination, look for the signs of tumor mass and then confirm by obtaining a contrast CT scan to assess for tumor masses. The next primary cause is nephrogenic DI. It can also be divided into congenital causes of nephrogenic and acquired causes of nephrogenic DI. Congenital causes include AVPR2 gene mutation, AQP2 gene mutation. Acquired causes include polycystic kidney disease, obstructive uropathy, nephrotic syndrome, primary aldosteronism, and drugs. On examination, look for any ballotable kidneys, which could be suggestive of polycystic kidney disease, any other signs of autoimmune disease and obstructive uropathy, and then confirm by obtaining CT abdomen to assess the integrity of the kidney, autoimmune markers to evaluate for autoimmune diseases. Lastly, screen for any medications that could lead to hypernatremia. For hyponatremia, the first cause to be elaborated here is fluid overload. In another word, dilutional hyponatremia. On examination, assess for failure status in the heart, such as pitting edema, pleural effusion, S3, gallop rhythm, murmurs, hypotension, while in the liver, check out for any enlarged liver, stigmata of liver disease. To confirm failure in the heart, you can obtain an echo for left ventricle function status, chest X-ray for signs of heart failure with a mnemonic ABCDE for liver failure, order liver enzymes, specifically serum bilirubin levels, and lastly, look out for other causes such as GI losses, hypothyroidism, renal failure, and drugs such as thiazides, cyclophosphamide, anti-epileptic drugs, as they can result in hyponatremia as well. Among the differential diagnosis of Hyper and hyponatremia include liver cirrhosis, type 1 diabetes, hypocalcemia, hypothyroidism, alcoholism, adrenal crisis, and cardiogenic pulmonary edema. So, principles of management in hyponatremia starts with recognition of the symptoms. When present, identify the underlying causes, and once sorted, immediately the management includes correction of volume disturbances, correction of hypertonicity, and stopping the offending agents. Close monitoring of fluid correction is vital, and perform serial neurological examination while correcting fluid to prevent occurrence of cerebral edema. For hyponatremia, the principles are in the following sequence, where you first recognize the symptoms and then identify any underlying causes. Subsequently, correct the electrolytes and water balance, stop any offending drug if any. Lastly, avoid rapid correction of hyponatremia to prevent osmotic demyelination syndrome. Recognition of symptoms in both hyper and hyponatremia are very important. In hyponatremia, the recognition of symptoms can help differentiating the severity and acuity of hyponatremia. In severe and acute hyponatremia, as the level of serum sodium decreases, the symptoms evolve from nausea and vomiting to coma. However, in mild or chronic hyponatremia, as the level of serum sodium decreases, the symptoms revolve around fatigue, nausea, dizziness, gait disturbances, forgetfulness, and muscle cramp. In summary, hyponatremia can be defined as serum sodium level of more than 145 millimoles per liter, while hyponatremia can be defined as serum sodium level less than 135 millimoles per liter. Hyper and hyponatremia are extremely dangerous and could be life-threatening. For hypernatremia, the life-threatening causes include hypovolemia, while for hyponatremia, it will be SIADH. Suspect hypernatremia in a patient when there is increased fluid excretion such as vomiting, diarrhea, and polyuria. History of brain pathology, cognitive dysfunction, dehydration, weight loss, and generalized weakness. There could be signs and symptoms of diabetes insipidus or other causes of hypernatremia. On the other hand, many medical illnesses are associated with hyponatremia, such as chronic heart failure, liver failure, renal failure, or pneumonia. These patients frequently present because of their primary disease, for example, with dyspnea, jaundice, uremia, or cough. Note that the symptoms of hyponatremia range from nausea and malaise, with mild reduction in the serum sodium, to lethargy, decreased level of consciousness, headache, and if severe, they can present with seizure and coma. The management approach for both hyper and hyponatremia include correction of electrolytes and water balance. Cautious and careful approach during correction are very much needed, as cerebral edema could happen in hyponatremia, while osmotic demyelination could happen in hyponatremia due to rapid correction. We have come to the end of this topic. Thank you.